All right, you are live, Dr. Lafian. You're good to go.
Awesome. Thank you so much. Hi, everybody. Thank you for joining our live today. I'm Dr. Anna Lafian. I'm a rheumatologist in Glendale, California, in my private practice, and I've been here for about a little over a year. So today we're going to be talking about all things immunosuppression and immunosuppressive medications, specifically in lupus. All right, so just as a generic kind of informational thing, what are immunosuppressive drugs? So, patients with lupus and autoimmunity in general essentially have an overactive immune system. So what immunosuppressive medications do is essentially they just calm the overactivity of the immune system. And so I always like to describe it to my patients as we're not trying to suppress your immune system and kind of make you have an underactive immune system. What's happened naturally because of the autoimmunity and because of the lupus is that your immune system is acting in overdrive. And so we just essentially want to calm it down and bring it back to this natural baseline. And so while immunosuppressive medications can make it slightly harder for patients to fight off infections and things like that, in general, they do a good job at stabilizing this overactivity. So this is just like a general preface for anybody on immunosuppressives. There's a general increased tendency of having infections. And so it would be helpful and wise to avoid people who have active colds, active symptoms, other illnesses, fevers, things like that. Clearly, washing hands regularly, maintaining good personal hygiene is helpful. And then, one thing is certain immunosuppressives and especially steroids can actually blunt your natural fever response. And so you may not notice that something's going on, that you're fighting something because you may not have that fever response. So it's really important to take sight of any kind of first sign of illness or infection or anything like that and notify your doctor. And as a matter of fact, I kind of encourage you to ask about this before getting on an immunosuppressant, right? So, doctor, if I start having signs of a UTI or if I'm on antibiotics for a UTI, should I continue the medication throughout or should I wait until that's completed? So that all really depends on what medication you're on, what the indication for the medication is, what doses you're on, but it's definitely a good principle to kind of have that foresight before something like that comes up. And then I kind of put this as like a generic kind of thing because I know it often comes up in my patients as far as like a question goes, but a very, very long-term immunosuppression can slightly increase risk of cancer development later in life. But it's very important to know this, that uncontrolled lupus and uncontrolled autoimmunity essentially also increases risk of cancer, as well as organ damage. And so in the grand scheme of things, you might be better off actually having immunosuppressants on board to definitely mediate and put that disease into remission or get it under control. And in the grand scheme might actually be reducing your chance of developing cancer in the long run. So the most common immunosuppressives in lupus and the ones that we'll talk about today are Azathioprine, also known as Imuran, Mycophenolate, also known as CellCept, and I'll kind of touch base on Myfortic as well, Methotrexate, Cyclosporine, and Leflunomide. And so my talk, with the caveat excludes hydroxychloroquine, which I know has been talked about in the series previously, and biologics as well, like Benlysta and Safnello. And, I'm sure it's kind of been talked about extensively, but hydroxychloroquine is the cornerstone of lupus treatment. Every patient with lupus should have hydroxychloroquine on board. It's essentially lupus life insurance. There is essentially no one best immunosuppressive agent for lupus. The choice is made based on what the patient's manifestations are, what side effect profiles the medication has, and whether the patient can tolerate them, other medical problems that the patient might have, and say other medications they might be using for other diseases that might be contraindicated with certain medications. So let's get to it. So azathioprine or Imuran is used to decrease joint damage, or it can decrease joint damage. It has also been shown by helping the liver and the kidneys in patients with lupus. It can also be used occasionally in treating lupus patients that have cytopenias, or which are basically low blood cell counts related to lupus. And this is a steroid-sparing medication. And what that means is essentially it'll allow for the reduction of the amount of steroid you're using and hopefully can eventually help get you off of steroids so that you don't have to have the steroid side effects. The medication is available in 50 milligram tablets. We use it in up to about, like we dose it based on the patient's weight. And so it's used in up to 2 milligrams per kilogram weight. The medication is a slow onset medicine, so it may take up to 6 to 12 weeks to actually start working. And even at up to 6 months, you may have the maximal effect finally manifesting or helping. And then as far as the medication goes, we use it in moderate disease. This is not used in organ-threatening disease usually. The way it works is that azathioprine is a prodrug, so it's essentially a little complicated to understand, so I tried to make it as simple as possible. We take azathioprine, the medication, in its inactive form, and then in the body turns it into an active drug, and that is actually what takes effect. And so mercaptopurine is the active drug in the body that's converted from azathioprine. And what mercaptopurine does is that it blocks an enzyme that's required for forming DNA. So, and why is this important? So it in turn reduces the number of cells that are rapidly replicating in the body, because with autoimmunity and lupus, you have this overproduction and ramping up of the T and B cells in our immune system. And so basically being able to block DNA synthesis, you are helping in decreasing the T and B cell overactivity. And essentially, like I alluded to at the beginning, suppressing the immune system will help stabilize that overactivity. So what are some side effects with Imuran or azathioprine? So we can see low counts, low white blood cell counts, platelet counts, and hemoglobin. Can increase risk of infection. You can get nausea, vomiting, or diarrhea. You can have low appetite with the medication. Some patients feel fatigue and muscle aches. And then elevated liver enzymes can also occur, even though this is a less common side effect, and rarely can cause pancreatitis. So you definitely should notify your doctor if you develop a new fever, new rash, or any bruising while taking azathioprine. And blood test monitoring should be done with this medication initially every 1 month. And then once you're on a stable dose, at about 3-month intervals and sometimes even longer, but it all depends on the dose you're starting on and how long you've been on the medication. But most of these, will basically say to monitor more closely at the beginning, and over time, once you're on a stable dose, you can increase that interval. And then I also advise my patients to avoid alcohol when taking the medication to avoid liver damage, preventing additional liver damage. So the next medication we'll talk about is Mycophenolate, also known as CellCept. And this medication is very regularly used in patients who have signs of kidney disease or who have lupus nephritis. The medication is available in 250 milligram tablets as well as 500 milligram tablets. And, it just depends, again, how severe the disease is. But typically we use it as a twice-a-day dosing, between 500 milligrams twice a day to 1,500 milligrams twice a day. Usually our target dose, depending on, again, severity of disease, is usually 2,000 milligrams to 3,000 milligrams daily. And, over time, depending on disease activity, we do tend to reduce that dose as well. And so you may not be on that high dose forever. The medication takes about 6 to 12 weeks to actually start working. And again, it acts as a steroid-sparing agent. It allows us to decrease the use of steroids. The mechanism of action of mycophenolate is that it targets an enzyme in the body, and the name of the enzyme is inosine monophosphate dehydrogenase. And again, same concept. It's that enzyme helps to create new strands of DNA. And by interfering with that process, we're making it more difficult for the cells to over-replicate and multiply, including the white blood cells in the body, which are responsible for the immune overactivity. And this medication, it's important to note, can cause serious birth defects. So one should not become pregnant while taking the medication, or should not use it through pregnancy. So more common side effects are nausea, vomiting, diarrhea, GI disturbances. Can also cause headache, dizziness, difficulty with sleeping. Less commonly, the infections, the myelosuppression, rashes, the low counts that we talked about. This medication rarely can also cause increased blood sugar and increased lipids, increased cholesterol. Some electrolyte abnormalities have been noted with mycophenolate use, things like magnesium, potassium, and calcium. I don't see it that frequently, to be honest. And then shortness of breath and some edema can also occur. And same with mycophenolate, needs blood test monitoring. So when you, especially for blood counts and liver function, initially, I do tend to test my patients more frequently, sometimes initially every 2 weeks, but eventually, 2 weeks to a month, and then over time, every 3 months should be sufficient. And then it's important to know, I put a little thing in the corner here that antacids actually interfere with CellCept. And so if you are taking antacids for GI upset, acid reflux, things like that, you should take the antacid at least 1 hour before taking your medication or waiting 2 hours after taking CellCept. So I put this here because mycophenolic acid or Myfortic, it can be helpful in patients who have really terrible, severe GI side effects and can't tolerate mycophenolate. These are essentially delayed release tablets, and it's an enteric coated formulation. And but it's really important to note that they don't have equal dosing. And so 1,000 milligrams of mycophenolate or CellCept is equal to 720 milligrams of Myfortic. So if you need to transition to that, your doctor will make that the appropriate dosing change. So the next medication to talk about is Methotrexate. Methotrexate is a DMARD, a disease-modifying anti-rheumatic drug. We use it first line for our rheumatoid arthritis patients. And so in lupus, we've borrowed the medication and we use it to treat the pain and swelling of the arthritis that can happen with lupus. And essentially, DMARDs are also known to decrease damage to the joint. And so it's important to make sure that we control the arthritis that's going on with lupus. It's not very helpful in organ-threatening disease. The medication is available in oral tablets, and it's also available in liquid form for injection. As a matter of fact, back in the day, I had heard that the liquid form can also be taken by mouth, and people have been able to drink the medication. We don't do that as much anymore, but I know some of our attendings back in the day mentioned that they've used it in that form. Methotrexate injected actually has some fewer side effects of the nausea and the GI stuff as it's bypassing the gut. It is absorbed better by the body and more consistently. So some studies show that taking the injection form of methotrexate has about an 85% absorption versus taking the medication by mouth has a big variable range between 20 and 80%, depending on your gut and depending on, gut microbiome and things like that as well. So most patients actually start to feel an improvement after 6 to 8 weeks of use. But again, maximum effect can take 6 to 12 months. So mechanism of action of methotrexate actually interferes with the production of folic acid. And folic acid is very essential and it's a building block essentially for growing cells in the body. So methotrexate blocks the growth of certain cells, including the cells of our immune system. How is it taken? So usual dose is between 7.5, even though it's a very, very small dose, to 25 milligrams weekly. Each tablet is 2.5 milligrams and so, the 7.5 dose would be 3 tablets once a week. The 25 milligrams would be 10 tablets once a week. The medication, obviously, as we alluded to, could also be used sub-Q. And patients taking methotrexate should take folic acid every day, and I'll explain why that is. So more common side effects are GI things, so nausea, indigestion. Some patients get diarrhea as well. A lot of my patients report feeling this methotrexate brain fog, usually the day of and the day after taking methotrexate, that feeling of you're almost coming down with the flu. Patients also report feeling some headache and irritability as well. There are other side effects like hair loss. It's usually pretty rare at low doses. And usually you will have hair regrow after stopping the medication. Sensitivity to the sun is quite rare, but you should be wearing sunscreen. And regardless of methotrexate use, lupus patients should be using sunscreen regardless. Obviously, as we're measuring liver counts and blood counts and things like that, the methotrexate can affect the liver and cause some liver abnormalities, but we monitor with our regular blood testing. And then with the lungs, so this is a more rare side effect. So methotrexate can irritate the lining of the lungs and essentially cause pneumonitis, which can manifest as a cough, a fever, and shortness of breath. And so if that happens while you're on methotrexate, you should definitely notify your doctor. And then methotrexate can also cause sores in the mouth, aphthous ulcers, and methotrexate also can cause serious birth defects, which should not be taken in patients that are trying to conceive or are pregnant. So I want to talk a little bit, because I get this question very frequently by my patients about the side effects, the nausea, the fatigue, the brain fog. A lot of patients taking this medication have these side effects. So these are the two tips and tricks that I have for my patients who have these side effects. So for the methotrexate brain fog, methotrexate actually stimulates a part of the brain. It's called the NMDA receptor. And a hack that we have, which I think has been borrowed by the oncology world, because oncologists also use this medication frequently, is that dextromethorphan, which is basically the main ingredient in cough syrups and DM cough syrups, can block that receptor, and therefore it can reduce that tiredness and that brain fog that patients feel on while taking methotrexate. So the dose I recommend is basically taking 2 teaspoons twice a day, the day before methotrexate, the day of, and the day after taking methotrexate. And then as far as combating the nausea and the vomiting and the GI side effects, vitamin A has also been found to be helpful. 8,000 units daily can prevent that nausea and that upset stomach, because vitamin D can regulate that intestinal lining and the cell proliferation and regeneration. So it can help with that GI kind of intolerance. One other thing that I have found too is that the patients that have a lot of GI intolerance and essentially get the side effects with like the oral ulcers and things like that, sometimes benefit from taking methylfolate as opposed to taking folic acid. And often those are my patients who have the MTHFR gene mutation or the SNP, the polymorphism in MTHFR. So they do better taking methylfolate as opposed to folic acid. And again, this is what I was alluding to, that folate, the B9 deficiency can cause the mouth sores in patients. And this is why we take folic acid every single day as a supplement to prevent this from happening. And because methotrexate depletes folic acid stores. And as an alternative, if folic acid, if the sores are still happening with folic acid or methylfolate, another alternative is to use leucovorin once a week, which is a folic acid analog, and it will help prevent these side effects. And the last few I'll talk about fairly quickly. Less used is cyclosporine, also known as Sandimmune or Gengraf. We rarely use it for kidney patients, and only select cases in lupus nephritis. It basically can also help with pain and swelling of joints, but again, rarely used for this indication. And what it does is it blocks the T cells of the immune system. The dose depends on your body weight, and the side effects to really look out for are hypertension. It can also be pretty difficult on the kidneys, and so this actually might cause your uric acid levels to go up, essentially causing gout, or like a gout-like picture, can cause headaches, abdominal pain, bloating, vomiting, nerve-related numbness and tingling, and some gum swelling. And lastly, Leflunomide or Arava is a disease-modifying anti-rheumatic drug, also used to treat the pain and swelling of arthritis that can happen with lupus. We can actually combine this medication with methotrexate if methotrexate is not doing the job as far as arthritis goes, or we can use it in lieu of methotrexate. And essentially, same concept. It blocks the formation of DNA inside the body, and helps with the stiffness and swelling and the pain in the joints. Usual dose is 10 to 20 milligrams once a day, and typically takes about 6 to 12 weeks to see full benefits. But within a few weeks, there are patients who do feel an improvement. Common side effects, so diarrhea. Diarrhea is very common. 1 in 5 patients will have diarrhea with leflunomide use, but the good news is that it does go away with time. And then nausea, indigestion, rash can occur, abnormal liver enzymes. And so again, blood count monitoring every 3 to 4 months, but more frequently at the beginning. I also advise my patients on leflunomide to avoid alcohol and to know that this medication can also cause serious birth defects. And that is it. I'm done. I realized that I went over a little bit, so I'm sorry about that, but there was a lot of information to cover.
That was great. Thank you so much, Dr. Lafian. We just had a quick question about that came through live on the folic acid.
Yes.
Asking about the dosing. Is that different for each patient based on the patient's case, or is that different for each patient based on the dose of methotrexate that you recommend, how much they should have daily?
So folic acid, 1 milligram every day, regardless of what dose you're taking of methotrexate.
Perfect. Okay. Well, thank you so much for your time.
Absolutely.
Thank you.